My name is Gracie Matthew. I am going to do a case presentation on asthma exacerbation. Today, I will be presenting the case study of a 34-year-old Caucasian female with a known history of asthma and seasonal allergic rhinitis who presented to the clinic with symptoms consistent with an asthma exacerbation. Her symptoms began to worsen over the past several days, which she attributed to increased pollen levels in the environment. She denies any significant past medical history aside from asthma and allergies and has no history of chronic illness such as diabetes, hypertension, chronic kidney disease, or coronary artery disease. Her only surgical history is a C section performed 3 years ago. Patient is a 34-year-old woman who presents with increased shortness of breath, wheezing, chest tightness, and a dry, persistent cough that started 3 days ago. She reports that her asthma symptoms are typically well controlled, but she began to experience worsening symptoms recently, which she attributes to the high pollen count during the spring season. She has been using her albuterol inhaler more frequently with a partial relief, but notes that the symptoms quickly return. She denies fever, chills, sputum production, or recent respiratory infections. She also denies any new environmental exposure or recent travel. She describes her breathing difficulty as a tight and wheezy, and it is worse at night and early in the morning. She is able to speak in full sentences but not increased fatigue due to poor sleep quality from nocturnal symptoms. She has not required emergency care or hospitalization for asthma in the past year. She denies chest pain, palpitation, orthopnea, paroxysmal nocturnal dyspnea, leg swelling, or recent weight changes. Family history. Mother has asthma and seasonal allergies. Father, he is healthy and live. She has only one sister. She is also healthy and live. And she doesn't have any family history of cardiac disease, diabetes, or autoimmune disorders. Social history. She is a non-smoker. She occasionally drinks alcohol and she works as a school teacher. She doesn't use any illicit drugs. Review of systems. Under general, she denies fever, chills, night sweats, or unintentional weight loss. Head, eyes, ear, nose, throat. She reports itchy eyes and nasal congestion, denies sore throat, sinus pressure, or ear pain. Under respiratory, she has wheezing, shortness of breath, dry cough, and chest tightness. She denies hemoptysis or recent infection. Cardiovascular. She denies chest pain, palpitation, edema, or syncope. Gastrointestinal. She denies nausea, vomiting, abdominal pain, or reflux. Genitourinary. She denies dysuria, hematuria, or urinary frequency. Under neuro, she denies headache, dizziness, or weakness. Integumentary, she denies rashes or skin changes. Musculoskeletal, she denies joint pain or muscle ache. And psych, she reports mild anxiety due to breathing issues. She denies depression or mood changes. Objective assessment. Her vital signs: temperature 98.7 degree Fahrenheit, heart rate 98 per minute, respiration 22 breath per minute, blood pressure 118 over 76, oxygen saturation 94% on room air. She is 5'4" tall and 130 lbs. Her BMI is 22.3, which is within normal limits. Her neurological assessment: she is alert and oriented times 4, no acute distress noted. She appears mildly anxious. Breathing appears slightly labored. Head, eyes, ear, nose, and throat assessment. Her head is normocephalic and atraumatic. Her conjunctiva is clear. Pupils are equal, round, and reactive to light. Her nasal mucosa pale and boggy, consistent with allergic rhinitis. no nasal polyps noted, oropharynx are clear without any erythema or exudates, no tonsillar enlargement noted. Her neck is supple, no lymphadenopathy, no tracheal deviation or jugular vein distension noted. Respiratory, mild to moderate expiratory wheezings bilaterally, prolonged expiratory phase noted, no rales or rhonchi present, no use of accessory muscles at rest, chest expansion is symmetric, percussion is resonant throughout, tactile fremitus is normal. Cardiovascular assessment, regular rate and rhythm noted, no murmurs, rubs, or gallops noted, no peripheral edema noted, capillary refill is less than 2 seconds. Gastrointestinal assessment, abdomen is soft, non-tender, non-distended, normal bowel sounds present on all four quadrants of the abdomen, no hepatosplenomegaly noted. Integumentary, skin is warm, dry, and no rashes or lesions noted. The diagnostic tests performed in the clinic. The first one is pulse oximetry to assess oxygenation. The second one is a peak expiratory flow to confirm airway obstruction. The third one is chest x-ray to rule out infection or any other abnormalities in the lungs or chest cavity. Then a rapid COVID test and a rapid flu test. These are the main tests performed in the clinic. Now I am going to talk about differential diagnosis. In a patient with a known history of asthma presenting with wheezing, shortness of breath, chest tightness, and dry cough, the most likely diagnosis is asthma exacerbation. However, it is important to consider other differential diagnoses. So, the first diagnosis is asthma exacerbation. The second one is allergic rhinitis with a postnasal drip. The third one, viral upper respiratory infection. Fourth one, acute bronchitis. The fifth one, pneumonia or lower respiratory tract infection. Actual diagnosis is mild to moderate asthma exacerbation. This diagnosis is based on several significant findings. He has a known history of asthma and allergies, and her symptoms have worsened with a seasonal allergen exposure. On examination, she showed signs of mild hypoxia with an SpO2 of 94%, along with wheezing and a prolonged expiratory phase. Additionally, she has reported increased use of her rescue inhaler, which is another indicator that her asthma is currently not well controlled. Here I am ruling out acute bronchitis because patient who comes with the acute bronchitis will have fever, malaise, chest discomfort, and productive cough. This patient did not exhibit any of these symptoms, so the acute bronchitis is ruling out. The same way, patient who has pneumonia come with a fever, chest pain, chest discomfort, and productive cough. Um, this patient did not exhibit any of these symptoms. Also, his chest X-ray was negative for any kind of infectious process. So pneumonia is also ruling out. Then allergic rhinitis with a postnasal drip, it is rolling out because it may be a trigger but not significant to explain hypoxia, wheezing, or increased use of rescue inhaler. And then upper respiratory tract infection is also rolling out because patient did not had any fever, sore throat, or rhinorrhea. Additionally, rapid flu test and a rapid COVID test was negative. So, viral upper respiratory illness is also rolling out. So, the final diagnosis is mild to moderate asthma exacerbation. Now, I am going to talk about treatment plan for mild to moderate asthma exacerbation. The first one is SABA, albuterol 2 puffs for every 4 to 6 hours as needed. The second one is steroids, and that is prednisone 40 milligram orally once a day for 5 days. The third one, inhaled corticosteroids, that is fluticasone 100 milligram twice a day. Then for allergies, continue with the cetirizine 10 milligram once a day orally. Then start on fluticasone nasal spray, that is two sprays BID. Then educate patient regarding inhaler technique, asthma action plan, and how to avoid asthma triggers like a pollen. Lastly, make an appointment for the patient for follow up in 2 to 3 days. And thank you for listening to my presentation. Thank you.